Thank you all for being here today, and thanks for tuning in. This is SMMC's first event with MarinHealth. We're super excited to kick it off with a topic that is so close to so many of us as mothers and caregivers. So we're very excited today to be able to host this session with MarinHealth. The topic is, of course, breastfeeding, transitioning to breastfeeding, what I wish I had known, with Dr. Rachel Yang. Dr. Yang is also a fellow SMMC member, so we're super excited to have her here. So a little bit about Dr. Yang. She attended Wellesley College in the University of Pennsylvania School of Medicine. She completed an internship and residency in general surgery at Stanford University, and she also completed a breast surgical oncology fellowship at UCSF. Dr. Yang is a certified lactation counselor and an international board certified lactation consultant. She's a member of the Academy of Breastfeeding Medicine and Institute for the Advancement of Breastfeeding and Lactation Education. And she started the first breastfeeding medicine clinic here in the Bay Area at MarinHealth, where she also works as a breast surgical oncologist. She advises many local lactation consultants, leads prenatal and postnatal education groups, and participates in a collaborative breastfeeding medicine research group. So we're super excited to be able to host this event with Dr. Yang, and she has a lot of amazing knowledge to share with you mamas out there. If at any point you have a question, I think you can just drop it in. You can raise your hand or submit a question. We'll keep a running log of what all the questions are and kind of address them either as we go or more towards the end. But we encourage questions. And again, thank you for being here and participating in our first event with MarinHealth. With that, I'd like to welcome Dr. Yang.
Hello, everyone. Thanks for being with us tonight. I am just getting used to this webinar situation. I realize that this is really meant to be more of a roundtable discussion, and since many of us are home on Zoom, I want to make sure that at each point along the way we pause at really each page or each slide that you see here to get some questions answered. So feel free to pop your questions in as they come to your mind. This PowerPoint is really a series of pages from a really nice prenatal education book that we have here. And I believe we're going to be able to get these shipped to most of you. And if you want a PDF copy, we have that as well. So don't feel like you have to take notes tonight. You will get a copy of this book. Just trying to figure out how to work the computer. 1 second. This has got a delay because I'm watching, so I'm going to go on this computer. Some changes here. Okay, so congratulations to all of you who are here in hopes of breastfeeding or who have already entered a breastfeeding journey with your first or second or more children. It's a really exciting and hopefully rewarding process, although it comes with so many challenges, and that's what I'm here to talk about today. This is an outline of the book that you'll receive. It covers every topic from breastfeeding, the early days of breastfeeding, to all the challenges that can occur with it. Oh, well. So breastfeeding medicine is a topic that not many people really understand, and it's a physician-led guide to breastfeeding. I see patients with any sort of breastfeeding problem in my clinic, and But essentially, I am someone who can support any challenges that occur prenatal, postnatal, and along the breastfeeding journey. Here's my contact info if I can be of any help to any of you. And if you notice something that I'm talking about today that might be a problem that you are encountering currently, feel free to reach out. So why breastfeed? So many reasons, but to highlight a few, for us moms, the benefits are just numerous, from cardiac disease prevention, diabetes prevention, cancer prevention. The benefits to babies are numerous as well. Their immune system has just immense benefit, and everything from inflammatory bowel disease, asthma, leukemia, prevention, the list really goes on. And I try when I see my patients not to focus too much on the health benefits for mom or baby, because although those are wonderful and vast, for me, what I think matters the most is the bond that's created between mother and child. And that's why, for me, the focus really is about initiating and maintaining an ability to directly breastfeed, meaning not having to exclusively pump. That's something we'll get into, but it can be a very challenging experience that most women don't find nearly as rewarding as being able to directly breastfeed their child at the breast. And some of that has been shown in research to be related to the oxytocin that is released for mother and baby, and the beneficial effects on the psychological development for babies and the prevention of mental health challenges in the postpartum period for mother. Of course, there's also the financial benefits of not having to buy formula, and the use of bottles and troubles that this creates throughout the day, and the inefficiencies in that, which is another reason that breastfeeding has quite a lot of benefit. I love this poster because it compares all the components of human milk to formula, and it's obvious here that the components of human milk are just extraordinary, and there's no way to replicate that in formula. So if we can give our babies human milk, it's a wonderful thing to achieve. It's not always possible, and I'm certainly able to help women when they're not able to feed with human milk, and it's a tough thing if that's the situation, if it's not been desired. But if we can optimally support all women in their ability to breastfeed, then it's a wonderful achievement for everyone involved. So preparing to breastfeed is a journey that starts from the first time you notice you're pregnant. The breast growth begins sometimes even before that first pregnancy test. Breast growth is something that I always find to be a reassuring factor during pregnancy, that we know that women who have larger breasts that grow more as they're pregnant tend to have better outcomes of breastfeeding and more breast milk production. It can be painful to have immense breast growth while pregnant. And here is a quick image of lymphatic massage, which can help women with significant breast growth that's painful and swollen during pregnancy or in the immediate postpartum period when a lot of engorgement is encountered. But one of the key things to note about breast growth, swelling, and engorgement that happens during pregnancy is that the supportive bra is just incredibly helpful, and that's because it releases some of the tension, some of the weight on the breast that contributes to further edema and swelling. So I talk to all my moms about how important a supportive bra is, both while pregnant and postpartum. Hand expression is one of the most useful skills that you can learn as a breastfeeding mother. I have a breast here that shows how to do it, and this doesn't replace an in-person class, but it's not too complicated. Essentially, I can see myself here. Hand expression involves making a C with your thumb and your forefinger around the areola, compressing back towards the chest wall, and expressing milk that way. It's not meant to be pushing towards the nipple, it's meant to be compressing back and rotating your finger in a circle. This is great if you are away from baby and you've lost your pump. To be able to know how to use your hands to express milk is something that can be really saving at a moment's notice. but also in the early postpartum period to be able to express milk if baby hasn't quite figured out the latch yet, and to be able to express a little into a cup or a spoon or a syringe to feed to baby. There are some moms who benefit from colostrum expression before delivery of their baby. Some of those women include those who have gestational diabetes, and that's because babies often have low blood glucose after being delivered and might benefit from some early supplementation of mother's colostrum. And being able to bring some syringes of frozen colostrum that have been collected from hand expression in the days leading up to delivery is a wonderful thing to have. Also, if someone's had a history of very low milk production, this might help stimulate their milk to come in. I think I'll stop there and see what questions we have. Looks like we don't have any quite yet, so anyone who have questions? Support during pregnancy can involve many things. So of course, seek the help of a lactation consultant or a breastfeeding medicine physician if you have had a history of, substantial breast surgery, to talk about how to prepare for breastfeeding in that setting. One of the most substantial breast surgeries that can affect breastfeeding are reductions. Implants can affect your ability to breastfeed as well. If you've had a history of breast cancer and plan to breastfeed, of course, involving a physician in your care is very helpful. And if you have anything coming up during pregnancy with the health of your breast, new pain or changes that are worrisome. Here are a list of some of my favorite supplies to bring to the hospital or to have on hand postpartum. I have a few of them on my table here for anyone in person who wants to check it out after. But to bring to the hospital, there's a lot of devices out there. I'll mention quickly some of the devices I don't like, but the devices or the items that I do think are important are probably first and foremost to bring a hands-free pumping bra to the hospital. Hopefully a pump won't ever be involved in your experience in breastfeeding in those first few days, but if you do have to use a pump for reasons that we'll talk about, having a bra to help facilitate pumping and not have to hold both flanges up to your breast is really quite helpful. And they don't have these available in the hospital in most places. So you can see one of these bras here. Bringing a organic or non-toxic nipple butter. Some of my favorites are the Earth Mama or Mother Love. And that can be used at all times leading up to delivery and in the days and months that follow to keep the nipples really moist and prevent cracking and wounds and pain. And also to bring nipple pads that help collect any milk that's causing your clothing to get moist and wet as you're producing your colostrum in those first few days. So those nipple pads that I like the best are not the disposable kind. The disposable kind can cause quite a bit of nipple reactions and irritations. So one of the more favorable types are the cotton or even the wool. The wool tends to be very helpful for those women who have vasospasm and are very sensitive to cold temperature changes. And the wool nipple pads I sort of refer to as sweaters for your nipples. So Lana, L-A-N-A, is a wonderful brand that you can purchase those through. Bamboo is another material that I find to be really useful. And let's see, one other thing I'll mention is people love the Haka. I am not a big fan of that. It applies quite a bit of suction. If you don't know what the Haka is, it's a silicone hand pump that inverts onto the nipple and draws the nipple into the pump to collect breast milk or colostrum. And it can cause a lot of nipple trauma. One alternative to this is something like the Haka Ladybug, which I have here, or what is the other name for it? Milkies, that's what it is. And those are passive milk collectors. So if you're wanting to collect those droplets of colostrum in the early days, using something that doesn't apply suction is ideal. And again, yeah, the Haka with the suction, not the best thing unless you're really trying to stimulate more milk production. Most people get overstimulated by it. Another thing I'll mention is a nursing pillow. There are many different brands. I think they all work great. And she's bringing these things up for me. And lastly, this is a nice item. If you're having a lot of nipple wounds, this can really help facilitate wound healing. I will quickly mention some of the items I really don't like. Lanolin, stay far away from it, in my opinion. I've been trying to advise our hospital not to give it out anymore. There's about a 6 to 10% frequency of women being allergic to it and developing a severe allergic reaction that is painful and burning and really interrupts breastfeeding. So I don't like the use of lanolin. I also don't like all the fads for Epsom salt soaks and saline soaks. Those can really denude the epithelium or the skin of a nipple and cause worsening nipple damage. So keeping the nipples hydrated and moist is really the way to focus on healthy nipples in the early postpartum period. And then, of course, I have to mention the vibrating massager that everyone's been buying. I think the brand name is Lovey. We'll get to it later, but massage is something I generally think should be avoided, and so does the Academy of Breastfeeding Medicine in their most recent publication on mastitis treatment. And the Lovey massaging device can really cause a lot of tissue damage and progression and worsening of mastitis. So I've seen a lot of unfortunate complications of using that device. And I'm looking at a question I have now. Do you not recommend the Haka in general, or just don't recommend it for the early stages? So I have a love-hate with the relationship with the Haka. It's certainly easier than putting an electric pump to yourself. I think the key with the Haka is what it's being used for. And we'll talk about that when we get to the discussion about oversupply or having too much milk. The idea of relieving engorgement and drawing out milk is something that is a real, unfortunately recommended to a lot of women and causes propagation of oversupply. So telling your body that it needs to make more milk. And the key with my approach to moms and babies is keeping the natural physiology going and not interrupting it by expressing extra milk, by letting baby demand the milk from mom and mom produce what the baby needs. And the more we interrupt that, the more we see women who are developing complications of oversupply, meaning they're using a Haka a few times a day and getting off several ounces of milk in addition to feeding their baby at all times of the day and night. And now their body thinks they need to make more milk. And that leads to a lot of problems down the road, especially in the realm of mastitis. Silverettes for nipples, that's another item I really don't like. You'll find me saying there are a lot of things I don't like, and that's because, in my opinion, and a lot of my colleagues' opinions, the capitalistic nature of our economy preys on breastfeeding moms and knows that we're all vulnerable and we all want this to work, and we'll buy whatever we need and whatever we think we need to breastfeed successfully. So there are just countless products that people can recommend and that are on Instagram and Facebook in the marketplace and Amazon that really lead us astray from what the body needs most, which is baby's mouth and baby direct breastfeeding in the case that is able to happen, which again, as I mentioned, not always the case. The silverettes specifically cause a problem because what they do is they they compress at the areola and cause a lot of the fluid or the edema to sit in the nipple and the areola. So you get more swelling of the nipple and areola. So babies have a harder time latching. So I see a lot of women who come and they say they have a circle around their nipple and areola, the indentation, and then this piece is really swollen. So this creates lots of problems. What was the product name of the nipple wound device? Or not device, but product. It's called Nursicare. And what they are, they've been rebranded, and I don't like it because they've made it more expensive, but if you want to buy it in a form that's just square and not circle, you can pay a lot less for it. And the original brand name is Polymem, Polymem. And it actually was developed many years ago for wound victims who have terrible wounds, and this material helps soak up the inflammatory secretions and help promote healing and decrease inflammation, and it works great for wounds of the nipple as well. So Nursicare Polymem. Ice or heat for initial engorgement post-birth. Ice for sure. Heat, as the Academy of Breastfeeding Medicine, which I can give the link at the end, their newest guidelines around mastitis and associated diseases talks a lot about using ice. And that's because what's happening in the early engorgement period and what's happening in mastitis is a lot of swelling, dilated blood vessels, dilated lymphatics that are contributing to sort of, I think of it like a swollen ankle, but of the breast. So inflammation, essentially. And when there's inflammation, we want to ice it to decrease that inflammation, to decrease the blood vessels being so large and distended. And so icing for engorgement pain, icing for mastitis, icing for, clogged ducts, which we'll get to. Do most lactation consultants accept insurance? That is very much based on your insurance plan. Breastfeeding medicine physicians like myself, I take all insurance. And so that's one of the benefits for seeing a physician, is that you don't have to deal with the insurance issues. And of course, it's always covered unless you're out of network. And then there's different coverages based on your insurance plan. And then the question of lactation consultants, some will cover private, some cover a certain number of sessions, some insurance only cover group sessions. Supportive bra, there are a lot of good ones that I like. There's one in particular on the Physician Guide to Breastfeeding are we going to be like keeping a list of all of these questions? I can actually email some of these resources at the end, since I don't. Perfect. Yeah, I don't have it off the top of my head, but yes, I can give some recommendations. Okay. Okay, mood and anxiety, which I'll just touch on here, but is a huge topic and a really important one. If you've ever had a history of anxiety, depression, or other mood symptoms, the chance of this becoming more prominent after birth is just huge. Unfortunately, a lot of women are discouraged from using their mental health related medications while breastfeeding, and the strong recommendation from every society that I know of is to continue those medications. And that's because the window of time where we're most vulnerable for mood disorders in our life is after giving birth, and preventing your emotional dysregulation and your ability and protecting your ability to care for your child is critical. And so these medications not only have almost all of the SSRI category medication or antidepressants, for the most part, been studied and shown to be safe for babies, but almost all other categories as well. There are a few caveats to that. So of course, always check with your doctor and feel free, to reach out to me directly if there's ever a question. Navigating the early postpartum days can be challenging. There's so much sleep deprivation. There's so many hormonal shifts. One of the first things that can really help in this transition is having skin to skin with your newborn. And that's because it helps to regulate your blood pressure, your heart rate, respiratory rate, temperature, and even prevent excessive bleeding from mom. It also is incredibly helpful for baby. We know it helps them regulate their glucose and their vital signs as well. And it certainly leads to improvement in breastfeeding outcomes. Even if you've had a C-section, all hospitals these days should be allowing mom to do skin to skin immediately after birth. This doesn't happen in all cases in the setting that either mom or baby are unstable or there's something worrisome happening, but when it can happen, that's wonderful. And if it can't happen with mom, it can happen with another caregiver. Skin to skin can happen with dad or grandma or sister, mom, sister, aunt, I guess. Then to talk about milk coming in, it's usually within 3 to 5 days after delivery. If you've had a long labor or C-section, it might be later. If you're a second-time mom, it might be earlier. It's common to experience pain in those early days. If you have concerns about your milk coming in and you're not sure if it's come in yet, it's something important to discuss with your physician or pediatrician. One thing to note is that there's a big focus on the shape of nipples, and people talk about lipstick shaped, looking like they've stretched too much, and really there's no perfect appearance of nipple. A lot of people also get told that their nipples are too flat or they're inverted. It will be a problem breastfeeding. I've seen people with completely inverted nipples and they breastfeed very, very easily. So most of the time, even an inverted or flat nipple can be pulled out by the baby's mouth or with a pump. And it's typically that people have been told there's something unfortunately wrong with their body that isn't. And I find that to be really unfortunate because it decreases our confidence in women's ability to breastfeed. So yes, there are some rare situations where a nipple cannot be fully averted, meaning it's just really tethered. And that's rare, but even in those situations with repeat attempts to breastfeed, usually the scar tissue pulling the nipple in relaxes and allows women to breastfeed. To touch briefly on positioning and latch, again, there's a big focus on latch. I like to say that it's not really about the latch, it's about the position, meaning that, mouth of a baby doesn't have to look perfect. We all get told that the lips have to be everted and the mouth has to open wide. There are lots of babies who breastfeed and transfer milk and excellent and grow and gain weight, and their latch doesn't look perfect and mom's comfortable and happy. All that matters is baby's gaining weight and there's not a ton of pain that mom is experiencing. So try not to be too fixated on latch, even though everyone in the hospital might be telling you to do so. It creates a lot of anxiety to really overly focus on this, and instead think about positions that are comfortable. And positions meaning making sure baby's belly button's facing your belly button when you're side lying. That's a woman's side lying here in the bottom left corner. And making sure baby's arms are comfortably wrapped around the breast or on, either side of the breast. Laid back and sideline positions, I think, are the two. And this is a woman doing laid back positioning, meaning you're kind of laying flat and the baby's facing down on your breast. These are two positions that unfortunately we don't teach women enough. They sort of been lost in our culture, and they're the two that actually help infants get some of the more deeper and more comfortable latches. They're especially helpful for women with really large breasts or women who have a really fast letdown. So this laid back position allows baby to have control of the milk flow, so the milk isn't pouring into the baby's mouth. The baby's actually on top of the breast. Here's some other positions that can be practiced, and I think cross cradle is probably the most common. And then some basics of feeding we'll get onto next. I think I'll stop and see if we have any more questions. Yeah.
Most like producing.
Yeah, we will. I think I might have a slide that talks about that, but most cases, no. Almost every woman has a discrepancy, and usually the discrepancy is quite large for whatever reason. And some people think it's because most babies have a side preference, most moms have a side preference. When we first start getting to know our baby and developing a breastfeeding relationship, learning those feeding cues is just crucial. Newborns have to eat often. They show different signs of being hungry. They might smack and lick their lips. They might turn towards the breast. They might be moving turning towards their cheek, moving their hands near their mouth. All these things are the subtle signs that it's time to feed baby. When a baby starts screaming and is frantic, usually you've actually waited too long to feed the baby. And at that time, it might be more difficult to latch. And you might need to calm down the baby by rocking or swaddling before you try and offer the breast. And, of course, everyone wonders, are they making enough milk? Is the baby getting enough milk? And in the early days, if we can avoid using a pump, that's certainly ideal, in my opinion. And for many reasons I'll talk about, but that leaves people wondering, am I making enough milk? The way to know is, are you hearing this gulping, the swallowing of milk? Are you seeing the baby swallowing in their throat as they're latched onto the breast? And that tells a lot. A baby, usually after several minutes of breastfeeding, for every woman, that length of time is different based on their flow and the amount of milk they produce. But for most, after the baby has done some audible gulping and swallowing for several minutes, they'll then become really sleepy and be very content and asleep at the breast. This might be after one or both breasts based on the mother's supply. And that is a sign that baby's gotten enough milk. And on the other hand, if a baby's swallowing, and then just keeps being fussy at the breast, you might wonder if something is going on where there's not enough milk. If there's a real question about it, the best way to answer that question isn't to pump, but is actually to do something called a weighted feed, where you bring the baby to a pediatrician or a lactation consultant, you weigh them with their clothes on, you breastfeed, and then you weigh them again after, and you see how many ounces they've gained. But if the baby's content and they're swallowing well, usually it's fine, and weighted feeds are not necessary for most moms.
So I've been told that our confidence is increased production, and I've with other moms that do players that don't even pump. So like, do we do that? Like, how else? No.
Yeah, the question, I'll just repeat it, is power pumping helpful to increase production? And the answer is yes and no. It can increase production some. My opinion that's shared by many is that power pumping does not increase it that substantially, and actually can be maddening for a lot of women because it's a whole hour or many minutes of time used to pump, and it's better to pump shorter periods of time more frequently if you're pumping. I'll get back to whether or not we should be pumping, but if you're pumping, that the frequency increasing and the duration decreasing is better than longer durations, more spaced out. And that has been shown to be true in several studies. So no, I don't encourage power pumping. I do find it in a time when women are already really vulnerable psychologically, asking them to pump for 45 minutes or an hour is just something that detracts more from their experience of bonding with their baby. The question of pumping to improve supply. The ideal situation is to be having a baby who's feeding at the breast from day one, who's cluster feeding to drive in supply, and the baby is your pump. And there doesn't have to be a pump involved, period. The reason being, once a pump is involved, there's all sorts of inflammatory cascades that happen, alterations in the microbiome, and challenges that happen down the road due to early pump introduction. Now, the caveat to that is there are some women who truly aren't able to make enough milk or need some help in those early days, and in that situation, a pump is necessary. But having there be true evidence that the weight gain is not appropriate and that mom's not making enough milk should happen before a pump is introduced. Because most of the time, if we let baby be the body's natural pump and we let mom's body respond to baby, that's when we get the best milk production. That's when the hormones are supporting the development of milk and supporting the baby's ability best to breastfeed. The question is, and what if the baby's not latching? If you have a baby that's not latching, you definitely need to pump. But the caveat to that is that we hear a lot about babies not latching, and most of the time that's because something has been interrupted in those early days. So has baby been taken to the NICU? Has baby been taken to a bilirubin light and someone's for some reason told the mom they can't breastfeed there, which is incorrect? Or has baby been given a bottle on the first day and it is now preferring the bottle already? And is a bottle being given before there's even reason to give it? But babies are meant to not have milk that is available to them until at least day 2 or 3 of life, when mother's milk comes in. So those first few days, they need to experience some amount of hunger and drive to cluster feed and bring in mom's milk supply. And is the inability to latch because something non-physiologic has interrupted the process. Most of the time, the babies will latch if everything is being done in a really supportive, holistic way around the mother and the infant. There are a few scenarios where the baby really won't latch, and that is incredibly, incredibly frustrating and challenging and just devastating for moms. So if that's the case, then yes, the pump has to be introduced as soon as a bottle is being introduced to the baby, and then have to focus efforts on how to support the baby in latching. This quickly discusses babies who love being held. Hunger cues can be very much confused with cues of babies wanting to be held, and some babies more than others. The best way to differentiate between the two is when a baby is done with the feed, hold the baby, don't just put the baby immediately into the crib or the bassinet, and see, is the baby satiated in mom's arms or being worn in a carrier? Well, then they're not hungry. If you put the baby in the crib and they start crying, it's usually that they're wanting to be held, not that they're hungry. Now, if they're done with the feed, they're done with the feed and then they're in mom's arms being held and swaddled and they're crying, that means they're probably hungry. So differentiating the two is challenging in the first few days, but becomes easier as you start to learn your baby's signals and know, okay, if I give a pacifier and the baby calms down, this isn't hunger. This is a desire to suck, to soothe myself, or a desire to be held by mom. And I think it's important to really recognize that it's biologically appropriate for infants to want to have contact with their mother. This stabilizes so many different things for them. It reduces their stress and improves so much of their development. And we're evolved for mothers and babies to be close. So that's what babies are trying to signal, that they want to be close in these early days, or the fourth trimester, as we call it. Do not time feeds is a really important topic. A lot of us have used all sorts of apps and are timing the number of minutes a baby's on each breast. This can not only cause a lot of anxiety for moms, but can give us false ideas about what successful breastfeeding looks like. Every baby's different. Some babies nurse for 3 minutes and they get a full feed. Some babies take 40 minutes, and that depends on the baby and on the mom. So I really encourage people not to be spending any time looking at numbers of minutes on each breast. Instead, be thinking about, is the baby gaining weight? Are they sucking and are they swallowing? Are they relaxed at the breast when they're finished feeding? And then in that case, there shouldn't be a focus on looking at the time they've been on the breast. And then to quickly discuss weight loss, during the first few days of life, babies almost always lose weight, especially exclusively breastfed babies. And it's normal to lose up to 7 to 10% of birth weight. Some people even argue up to 12% is a normal weight loss. But certainly up to 7 to 10% is acceptable. When you go beyond that, then a conversation is typically had with a pediatrician about introducing formula or pumping to give some express milk on top of breastfeeding to get the baby back to a point where they're gaining around a half to 1 ounce a day until about 3 months of age. That's the goal. And it's not uncommon if you had a C-section or difficult labor for it to take a few extra days for the milk to come in and for the birth weight to get back to where you want it. You really want the baby to regain birth weight by 2 weeks. And so really understanding if breastfeeding is going well is mostly looking at baby's weight. Seems like we have some questions here, so I'm going to jump to that. When do you recommend introducing a pump? Assuming breastfeeding is going well, I usually say try not to before 6 weeks. The breast, and especially in the first month, is incredibly reactive to pumping. For most women who don't have an issue creating an appropriate supply of milk, the pump can be very stimulating and so can lead to an oversupply very quickly. That's very difficult to reverse. Breastfeeding is going well, but you want to supplement bottle feeding, breast milk, due to whatever reason, how long do you recommend delaying introducing a pump? Another great question. Again, I really try and have people hold out till 6 weeks to pump because it can be, it can cause so much mastitis, and that's really what I see day in and day out: mastitis and blebs and abscesses and long list of problems that I'll show quickly in one slide to come. But there are moms who need to pump, and there are moms who want to pump, and that's okay too. If you're going to pump, I say make sure that you're pumping only what the baby's drinking. If you're pumping much excess of that, more than 1 or 2 ounces going in the freezer every day in addition to what you're pumping, that's when you get into oversupply territory. And these pictures of big freezer stashes give a lot of false ideas that moms should all have a big freezer stash. And unfortunately, that leads to a lot of challenges that come after development of oversupply. The next question is the contact of mom the same as dad, or is it only the mom that counts? I don't know the data on that. I do know that having skin to skin and close contact with other caregivers, whether that be same or different gender, is certainly beneficial, and that's been studied. I don't know if there's a benefit to mom versus dad in terms of skin to skin. I would imagine there probably is, that there is some ability for baby to really know who birthed them, but I think that that it's probably very close to comparison, and that the truth is babies need a warm, loving caregiver, and whoever that might be is someone who can provide and meet the baby's needs. During the feed, should we switch sides? That's a great question. Most moms do switch sides, especially in the early days. with moms to develop a more substantial supply, they often don't need to use both sides. And so that's really about what baby looks like after one feed. If baby's totally zonked, don't wake them up and irritate them to put them to the other breast. If they're still rooty and they're still looking like they're hungry, then offer them the other breast. But the assumption that every mom needs to feed from both sides at each breastfeed session is a false one. And it's really good to know that and be aware that there might be a time in your breastfeeding journey that you need to feed from both breasts, and there might be a time that you don't. The next question is, my baby's 14 weeks and his feeds are very short. They can be 5 minutes, 10 minutes is his best. I've been told he's at a distractible phase of feeding. Yeah, that is the age for distraction. I'm nervous about my supply dropping. I had supply issues at the beginning. I find he feeds best when he is sleepy, so I feed him at both the beginning and the end of the wake window, which means I feed him every 30 minutes. Can you speak to the distractible phase? My baby is also in that phase, so I feel your pain. My second born, my first one did not do the distractible nursing as much. So I think it depends a lot on the temperament of the baby, how interested they are in the outside world. All babies recover from it eventually, if we want to, say that something they need to recover from. The best way to approach it is to try and go in a room that's dark, sound machine, get them away from distractions, because usually what they're just interested in seeing their sibling or the dog or the new picture on the wall. So minimizing distractions, and then just knowing that babies will eat if they're hungry. And so usually they are pretty satiated and not needing a ton of food if they're wanting to go look at the dog. So letting them lead the way and not forcing it. When you really try and force a baby to stay at the breast when they don't want to, that can create other problems like breast refusal. So allowing them to feed more frequently during the time that they're having a developmental leap and more distractible is okay. Certainly a baby who's very distractible might be wanting to be on the breast every 15 minutes, pop off, go back on, and that's okay. I think a lot of breastfeeding is just about letting the baby lead the way and knowing that babies are evolved to get the milk they need, and they usually are not going to starve themselves because they're so distractible. But this means that breastfeeding looks very different at different ages and stages. This next slide talks about early supplementation. And it's important to know that there are different options. There's donor breast milk options and formula also, of course. There are different reasons to have low production. First-time moms can have a delay in milk coming in. There's some moms who don't experience significant breast growth and don't have the same response to the prolactin or the hormones that lead to breast milk production for reasons that we don't always understand. And there are some moms who have anatomic differences in their breast that never developed the way that they were expected to when they were younger. And any of these situations, these women would benefit from seeing a provider and figuring out what the cause of the low production is, and seeing if they might benefit from any sort of pharmaceutical or herb to improve their supply. That's a topic that could spend an hour talking about, and it's complicated, but certainly gets the support you need. There's a lot of different things that can be done. Triple feeding is often recommended to moms when they're leaving the hospital or in the early postpartum period when they don't have enough milk coming in. And what that means is you do 3 things. You pump, you usually start with breastfeeding, then you pump, then you feed a bottle. So that's why it's called triple feeding. It's important to know to use this very cautiously. And unfortunately, so many women leave the hospital being told to triple feed and no one follows up with them about when to discontinue that. This is something that really contributes to crises in maternal mental health, because as you can imagine, you're either feeding or pumping or breastfeeding all day long, and the amount of sleep deprivation can be severe. So I tell women that 1 week at 2 weeks, the very maximum of doing this. And after that, they really should transition to, if there's a problem, with baby getting milk from their breast or with their production, transition to mostly pumping and breastfeeding a few times a day, not trying to do every feed with all 3, but making sure that baby has a few opportunities every day to stay familiar with the breast. Again, as someone who's needing to triple feed or someone who's needing to continue this significant degree of pumping is usually something that's really needing the help of a provider to sort out what's going on here and why there hasn't been an ability to get the direct breastfeeding going and get the support to eventually transition off this if possible. The triple feeding is not a long-term solution. I think we briefly discussed short feeds. with the distracted baby, but also when mom has a lot of milk, feeds can be very short. And cluster feeding is normal when babies want to feed a lot more to get mom's supply to come in. Quickly to talk about poop here, something we all think too much about after our babies come. You know, what to expect in the first week. What we care about most as breastfeeding docs is not what's happening with urine, but what's happening with the stool. And that's because urine can relate to how much the baby's fluid is shifting after being born, but stool or poop is really about what's happening with the breast milk. So when babies first have a poop in the first few days, it's meconium, and that's this green sticky material on the top. And then it starts transitioning to something in the more orange color, and then it finally becomes a seedy yellow color breast milk poop. And when we get to this breast milk poop, this is very reassuring, especially by day 5, that breastfeeding is going well. We try and think about the number of stools corresponding to their day of life. So you want 1 stool the first day, 2 the second, and these really help us be confident that baby's getting the milk they need. And of course, this varies based on if you're a first-time mom, second-time mom, but some idea that we're not staying with meconium more than a few days. Quickly looking back at the questions. I assume introducing a pump within the first 2 weeks is okay if you have an oversupply of milk to help get it out, or do you recommend manual expression? This is a great question. It is contrary to most belief that pumping when you have an oversupply is helpful or beneficial. It's actually quite the opposite. Oversupply means too much milk. Pumping or hand expression leads to more milk coming out, then propagating the cycle that more milk is going to be produced and you have more of an oversupply. The best way to resolve this is to not express more milk, not to be pumping, not to be hand expressing, and to just meet the baby's needs. Baby nurses all day and night, and you allow yourself to experience engorgement, even though it might be uncomfortable, and that can be avoided with ice and ibuprofen. But after a few days of engorgement, that sends a signal to your brain to stop making so much milk. And that is how the oversupply is treated. Although expressing milk to relieve the engorgement and to allow the baby to latch more easily is an immediate fix, it makes the long-term problems much worse. And so much of my education with patients is about letting themselves experience that engorgement so their oversupply can actually self-correct. So not getting in the way of your own body doing what it wants to do by helping to resolve this. And if, of course, this is challenging and it's not resolving, involving a physician to help you with it. There are sometimes people who have such an oversupply, they need medications to help them with that process. Another option with a major oversupply is block feeding, meaning every feed, the baby only gets 1 breast. The next question is, I've heard that self-massaging the breast during feedings can be helpful for baby and supply. Do I recommend or discourage that? Using them similar to the massaging tool that I discussed earlier. Massaging for women who have very low supply, there are some women who find that it improves their supply. I think the vast majority, when they really look at it and compare the milk they produce, don't see a difference. So because of that, I don't widely recommend it. It's sort of one more thing that makes breastfeeding challenging. We stack up all these things that people need to do, and this is another one of those things. Once in a while, a woman really says it makes a difference for her, and then if it does, that's great. You know, you're certainly welcome to massage gently if you feel like it helps your production, but most of the time it doesn't make much of a difference, and it's just added work and sore hands, to be honest. The massaging tool that I discussed earlier should not be used for massaging for increasing supply. It really can cause inflammation of the breast, more pain, and damage to some of the ducts. So if you're going to massage gently and don't use a massaging device. Quick suggestions as far as supplements to boost supply. It is not a myth that oats and tea can increase supply, but they do so quite modestly. The things that improve supply are really at a more therapeutic dosage, which is mostly capsules. And those herbs, probably the ones I like most is number 1, moringa, and those are capsules. And the second being goat's rue. There's several others I like as well, turbungan and shatavari, but Moringa and goat's are probably the two most helpful for different reasons. Goat's especially if you have had any history of diabetes or insulin resistance, or if you didn't get much breast growth during pregnancy. And Moringa is especially helpful if you had a good supply and then it dropped off. And that is because, and the reason those supplements work more than the oats and the teas is they're just higher dosages in the oats and the teas. Another question about boosting supply. A baby 8 months old who's been breastfeeding. She has recently been taking extra milk from bottles, especially in the evening, in addition to when you breastfeed her. And you've been using a lot of your frozen milk. Baby's gaining a ton of weight, so you might be overfeeding, but she seems hungry. Pediatrician said feed her if she'll eat. Great question. Overfeeding is something I see so much of. A lot of women get convinced by various people in their lives that they're not making enough milk when they really are. If anyone is, wanting to know what a normal milk production is, it's somewhere on the order of 1 to 1 1/4 ounces per hour, so around 24 to 30 ounces per day. There are babies who will drink 60 ounces because they just love drinking milk, and it will go and go and go. And babies are not unlike adults. We like fast food, and we will often eat till we're way too full. And we like sweets, and breast milk and formula is very sweet. So I don't feel that the pediatrician is correct in saying feed if she'll eat. There's a difference, and most breastfed babies will not need to take more than 3 to 4.5 ounces in a bottle ever. So babies getting these huge bottles usually are being overfed, although I can't speak for every situation. And the best way to figure out if a baby's hungry or not is really understanding what's happening after that first breastfeeding or that first bottle, smaller bottle, that's making the provider think that baby's still hungry. And usually this is because baby's really fussy, or baby is wanting to suck to soothe or use the milk to soothe, not because they actually need it for calories. And so if you can breastfeed and then hold the baby and the baby's comfortable, then it's not hunger. And if you're bouncing the baby or you're rocking or you're baby wearing and the baby's happy, it's not hunger. So that's the easy way to figure it out. And also, just having a sense for what you think the baby is taking during the day. Also, anytime a baby is acting much more hungry in the evening, that clues me into something called the witching hour. Most newborns really have a lot of fussiness from the time of like 4 till 10 p.m. And that's because their neurologic system is just overdone by the end of the day. And they're needing more help soothing themselves and dealing with all of their fussiness and emotion. And it doesn't mean that they necessarily need more food. A lot of moms say that they don't feel their breasts are as full in the evening, and that is completely normal and physiologic. Just like adults, we are healthier, babies are healthier when they have more volume earlier in the day, less later in the day. They're not meant to have huge volumes of milk later in the day. That's not how any mom's milk production works. And so typically this evening fussiness that prompts a lot of bottles is just more related to babies needing help being soothed when they're ready for bed or being overtired. Currently on day 2 of baby's life and being asked to triple feed every 2 hours to prevent low blood sugar from recurring in baby. Any advice for other ways of preventing low blood sugar? This feels tough. I would say this is complicated. Reach out to me. I will message my info to everyone, but you can also find me by Google. I'm happy to see you. I fit people in with breastfeeding problems very quickly because, as you know, the new baby, things change hourly. But every 2 hours is a lot. I would say every 3 hours is fine, and a 4-hour stretch of sleep overnight is fine as well. And if that's not cutting it, then you can always supplement with some formula until the milk production picks up. But I would have to hear a little bit more about what the low blood sugar is referring to. And usually if a baby's out of the hospital, there's not truly a concern about low blood sugar. So I wonder if that could be some, misunderstood advice or bad advice, to be honest. So feel free to reach out. I had an oversupply with my first and was recommended to take sunflower lecithin. Do you recommend this as a supplement? Sunflower lecithin is a phospholipid emulsifier, so it thins breast milk. And what that helps with is people who have recurrent areas of inflammation or mastitis, compressing the ducts, and it helps to allow the breast milk to flow more easily through the ducts. and make their way out of the breast. It's not necessarily of any benefit to someone with oversupply unless you're having recurrent issues of mastitis or inflammation. Okay, we'll move on. So let's see, this is more about baby stool, but big picture is there can be a lot of focus on babies being really gassy, babies having too many poops, babies having green poops, mucousy poops. So many of those symptoms are actually related to mom having an oversupply, which not all pediatricians understand and most moms don't understand. So if you have a lot of milk and your baby's spitting up a lot, really gassy, or having any of these poop changes, it's something to be aware of and something to talk to a provider about. And if your baby's having a ton of frequent stools, they often have diaper rashes, and zinc oxide at the highest concentration, 40%. Burt's Bees has a good option for that, can really help protect baby's bum. And, this kind of leads into the question of milk protein allergies and such. If baby has a true milk protein allergy, there's usually a red flag signal such as blood in the stool or difficulty with gaining weight. And that's when you really start wanting to talk about food elimination. But the frequent stools, the mucus stool, the green stools, those are all within the realm of normal for the most part, unless it's just an overwhelming amount of mucus. But the green discoloration and the liquidy stools can really just be a sign of oversupply. How to know if your baby's getting enough milk. We talked briefly about this, but you want to make sure they're getting enough poopy diapers, making sure they're gaining weight enough. If your baby's lethargic, if you're feeling they're not nursing or not taking a bottle, that's of course a concern. And if you see these red crystals in the diaper, this is something that is a concerning sign. Breast milk changes early on. The breast milk is colostrum, it's thick. It's very difficult for it to come out with a pump and more easily expressed with the hand expression. It usually changes around day 3 to 7 into a mature milk, which is white in color and more liquidy. Nipple care. I think we already touched on this as well, but nipple wounds are common and most commonly due to a mother being too engorged, where a baby's having a hard time latching onto the nipple. So unlike what many people are told to pump or to hand express to relieve some of that engorgement, that just perpetuates oversupply and causes more breast milk stimulation and more breast milk production. So instead, something called reverse pressure softening can be performed, where you actually lie flat on your back and use your hands to press some of the swelling out of the nipple in this kind of fashion. And that can help relieve some of the engorgement at the tip of the nipple so baby can latch. Some other things, if you're having nipple wounds, keeping them really moist with something like the Earth Mama or Mother Love nipple butter and putting a gel pad over that to really keep the moisture in place can be exceptionally helpful. And again, if you're engorged, a sideline position can oftentimes work more easily than the cross cradle. So here are some of the things that I probably see the most of. Challenges for mom in the early days. Pain with breastfeeding the nipple or the breast can be caused by all sorts of issues. Can be caused from having a baby clamp on the nipple if the milk production is too high, clamp on the nipple if the milk production is too low. Can be caused by dermatitis, which can be from any sort of product applied to the nipple like lanolin. A lot of times people are being prescribed antifungals for no good reason, which if in case I don't get to it, in the last year or two, there's been some really good scientific evidence and studies coming out that thrush is not an actual diagnosis for breastfeeding moms, that if moms have pain and any symptoms previously thought of as thrush, almost always they can be diagnosed with an alternative diagnosis that when treated, their pain will go away. And unfortunately, women are still getting prescribed fluconazole or diflucan or topical antifungals that cause a lot of irritation of the nipple when there's really no such thing as candida or yeast of the nipple. There can be of the infant's mouth thrush, but that is not something that can transmit to mom. This is a really common misunderstanding that I'm frequently discussing with different healthcare providers. So don't be surprised if, unfortunately, you have a healthcare provider yourself tell you that you need to be treated for thrush when really, unfortunately, that's not the case. Other things I see are nipple blebs. This is usually related to mastitis and overproduction, not from the baby pulling on the nipple. People can get nipple pain from something called DMERS, which is dysphoric milk ejection reflex. And that is something when someone experiences actual emotional symptoms like despondency, anger, anxiety, sadness while they have a letdown, and that can be associated with intense pain and nursing aversion. That can make for a really challenging breastfeeding journey. And finally, vasospasm. This is where you see this white blanching of the nipple and a lot of pain, especially with temperature changes like cold, and especially, when you're stepping outdoors. One of the best ways to treat that is to stay really warm, to use the wool nipple pads, and to seek help if you need to get medication, which treats it very effectively. Mastitis, you can see here. The big move has been away from the treatment of mastitis with antibiotics, instead treating it with probiotics. There's a lot of good evidence that antibiotics are really overprescribed and for the most part not necessary. Again, to touch on massage, this is the new guidelines are not to massage when you have mastitis, to instead focus on ice, ibuprofen, and not increasing the feeding. So increasing the feeding, increasing the pumping, that just causes more breast milk to develop behind the inflamed segment and causes more inflammation in the breast. Most women with mastitis, though not all, have an oversupply, so that is a fundamental focus of treatment. Plugging used to be something that people thought of as a stone in the milk ducts, and we've come to understand in recent years that it's really not a stone in the duct. It's that there is a ball of inflammation around the ducts and they're compressing the ducts. You can see in the picture here that the ducts, these little yellow tubes, they shrink when all of the inflammation around them compress them, but there's not actually a stone of milk in the duct. And so what that means is massaging to try and get a stone out is of no help, and trying to increase the feeding, increase the pumping to pull a stone out is not effective either. What's effective is decreasing that inflammation with ice and ibuprofen and decreasing the milk production on that side if you have an oversupply. And the other thing that can contribute to mastitis is if you're using a pump. Unfortunately, there's a really important relationship between baby's mouth and the microbiome, the bacteria that are in baby's saliva. They actually need to travel backwards up through mom's nipple. The saliva goes up the nipple into the ducts to colonize the ducts and create a really healthy microbiome. And when that gets altered because of a nipple shield, because of the pump where there's now plastic in place and not a baby's mouth with all the bacteria, we see the microbiome change, and the microbiome changing causes mastitis and pain and blebs and all sorts of challenges. So that's why the main focus on getting away from the pump is so important, because a lot of these problems result in women who are doing pumping. And for women who can't avoid pumping because they have a baby who doesn't latch or they have a baby in the NICU, then helping to support them and prevent some of these complications with the use of a probiotic to create a healthy microbiome, that's something that I really try and focus on. Here's a picture of a lopsided breast, the question I had earlier. Definitely, most women have one side that produces more than the other. The way to try and balance that out is to feed less from the larger side and feed more from the lower producer side, to try and stimulate more on the low production side, stimulate less on the high production side, even if that means allowing for some engorgement. All right, I have a question about tips for breastfeeding when the baby has teeth. Babies who have teeth, it's not the teeth themselves that cause problems with breastfeeding. It is that the baby is biting to experiment, and babies are little scientists, and so they are wanting to know what happens when I bite on the nipple, and they might see a reaction. Mom might scream or shout, and they don't quite understand emotions yet, so that might be funny to them or interesting to them, so they might try biting again. So my best advice is to try your very best to not react at all when baby bites and to immediately stop breastfeeding. Let the baby breastfeed again, maybe in 15 or 30 minutes, but make it very clear that when a bite happens, no more breastfeeding. Even if it's tough to hold out like that, they learn cause and effect very quickly. And they know that if they want to breastfeed, they can't bite. And that doesn't always happen right away, but with recurrent reminders that biting leads to stopping breastfeeding, most babies figure out that they don't want to be biting if it takes away their food. For probiotic recommendations, Lactobacillus fermentum and Lactobacillus salivarius are the two that have been studied in randomized trials for breast health. The one product that I like that has the highest concentration is called Claire with a K, K-L-A-I-R, Claire Labs Breast and Baby. So challenges with babies, there are some babies who like to be held more than others. If you're struggling with this situation involving the help of other providers in your home, whether that be family, friends, nanny, also making sure you have some breaks for your mental health and making sure that you have other options to soothe the baby. So whether that be a bouncy ball or yoga ball bouncing up and down is a wonderful option. Baby carrier, pacifier, of course. How long should we be breastfeeding for? How long is too long? This is a question I love, but it's probably a bit controversial. There's a lot of anthropologists that have studied what breastfeeding looks like in other parts of the world and in non-Western communities. And it has been shown that in non-Western worlds, babies often breastfeed until very late ages, anywhere from 4 to 8 years old, which most of us in America don't know anything about. So how long is too long? In my opinion, nothing's too long, but I'm a radical. So, but I think as long as you find joy in it. And so if you are not finding it joyful after a month, then forget it. You enjoying baby, loving up on baby and being emotionally present always trumps breastfeeding, in my opinion, even though this is my job and I love it in so many ways. But if you find it joyful and bonding to be breastfeeding till you're sick, till baby's 6, which I know a lot of people have done that. I think people don't talk about it much. Then go for it. There's certainly benefit as long as breastfeeding happens. So as long as breastfeeding happens, it's more protective for mom's cardiovascular health, cancer reduction, for baby, as long as breastfeeding continues. Even if there's very minimal milk, there will always be antibodies, there will always be benefits to the immune system, and there will always be benefits to bonding. So it's really just about the unique mother and infant dyad, and there's no two units that are similar. Every mom and every baby is different, and it's just about what feels good to you, and finding and figuring that out as you go along. That can be something that changes along the way. Mm-hmm. Yeah.
So my baby never last, so I have a pop, and I was talking to the lady, like put stuff because you don't want to buy it. But then what you do is how does it pay for it to heal? There's nothing that you can do besides every couple of hours.
Yeah.
So like what do you do? How does it take recover? Like what in the meantime?
Yeah, the question is about bleeding nipples and really bad nipple wounds, and it's hard to really recommend anything other than like see a provider. So yeah, it's see a breastfeeding medicine doctor if you can. There's not a ton of us out there. Nipple wounds are tough, and it's hard since I didn't see your nipple wounds to know what category they were, but they're complicated. Most nipple wounds, 95%, will resolve with a lot of nipple butter and the gel pads, keeping them moist at all times, or the Polymem product that I showed. And there's sometimes where that's not the case. And some more advanced like wound healing product needs to be used.
The breast size changes, right, for the breastfeeding journey. How do you fit the flange?
Yeah, this is a great question about how do you fit the flange based on the changing size of the nipple. And certainly nipples change during pumping and during breastfeeding. Mostly they get larger in the early breastfeeding time. As you're doing more pumping, they're going to get larger as well. And in my opinion, the flange size is a bit of a obsession lately with lactation consultants and another marketing ploy a bit. But as long as it's comfortable, as long as you're making adequate milk or as much milk as you should to meet the baby's needs, that's all that matters. Ideally, you don't want your nipple touching the plastic, so you don't want it rubbing the plastic as you're pumping. And so I always err on the side of larger flanges. I know the fad is to go smaller, but my preference is larger because I see a lot of wounds from the really tight constriction of the nipples by the really small flanges. But really all that matters is you're comfortable and you're making milk. And you don't have to keep changing flanges because your nipples got a little bit bigger, as long as the comfort and the milk production continues. Can the sleeping position on the belly impact the breast production at night? This is the question. No, it can't impact breast production. It just might be uncomfortable. So most women get a little more engorged overnight and don't find it comfortable to lay on their bellies, but it doesn't inhibit breast milk production, no. Breast milk jaundice is briefly mentioned here. It essentially can be caused by many things, or baby jaundice, excuse me. Breast milk jaundice is a physiologic or natural reaction to breast milk and the liver, a relationship causing some yellow discoloration of the skin and elevated bilirubin, and this is normal and resolves with time. There is also a pathologic or unhealthy jaundice, meaning it's because the baby's not getting enough breast milk. Regardless, the decision about when a baby needs to go under a bilirubin light is really up to the pediatrician. Is a complicated decision, but making sure that you have an awareness of, is the jaundice related to breast milk production or baby not getting enough milk? And if so, trying to augment breast milk production. If it's not related to the breast milk, if the baby's gaining weight and it's just that they purely have yellow discoloration because of the breast milk, but not because of an insufficient amount of breast milk, that's not a reason to switch to pumping. And there can be some confusion around that. But essentially the key is baby gaining enough weight? Is baby pooping enough? And that's the focus on determining if baby needs more or less milk, not if they're yellow or not. Here's the infant thrush that I mentioned. This is definitely a real diagnosis. It can look similar to something called milk tongue, where the milk is very white. If you can scrape off the black or the white easily, it's really from milk and not from thrush. And again, it can't be transmitted to mom. To touch briefly on nipple shields, I think this is important. All too often, moms are given nipple shields when there's a concern about latch, when there's any difficulty breastfeeding. And it's really not a long-term solution. It can lead to babies learning to breastfeed inefficiently, clamping on the tip of the nipple, not clamping and getting a really deep latch. So they often learn really ineffective strategies for milk expression. And it also can lead to a decrease in mom's milk production. There's been some good studies on that. So it's unfortunately not, and women are not informed enough when they take a nipple shield that it can affect their production and the baby's ability to latch. So my preference is not to use nipple shield unless you're really in dire circumstances. Talking about babies' noises, a lot of moms ask about clicking sounds. This does not necessarily mean there's a problem, but often relates to there being a lot of milk or there not being enough milk. If there's a lot of milk, babies might be really uncomfortable after your letdown happens and they might be coughing or choking. That might be a time to try something called laid back nursing or talking to provider about decreasing your milk production. And with lower production, babies might latch, but then they are not getting enough milk and then they cry or they're falling asleep tired at the breast. And that's in the setting where you need to be supplementing. The next steps after that initial newborn period in the next 3 to 6 weeks, there's a lot of differences in how babies sleep. There's some babies who sleep a lot at night and there's some babies who sleep very little. And this is to do with baby temperament. Some moms get quite worried about letting a baby sleep at night and are they going to get mastitis? There is no data to support mastitis is related to longer stretches of sleep. You will get more engorged. You can get even breasts that look red. That doesn't mean you have mastitis. It's not recommended if you're engorged overnight to pump and relieve that milk because again, that leads to more milk production and more engorgement. The best thing is to let your body match the baby. If baby is naturally sleeping longer stretches overnight, they're likely, and without the use of a bottle, they're getting a lot of milk from you. And they don't need to be woken up at night. And your body needs time to adjust to that, to learn to have less production overnight and meet baby's need when baby's feeding during the day. If baby's doing a lot of cluster feeding at night, they might be trying to drive your supply in. And this is where we see the baby really leading the way with whether they're sleeping a lot because you have too much milk or they don't need any more, or if they're doing more cluster feeding because they do need more. Quickly, birth control and breastfeeding is safe when breastfeeding, but if you have a lower supply, you could be very sensitive to some of the birth control options. If you're going to use the pill, estrogen is something to be avoided because it will decrease breast milk production. A lot of women think they can't get pregnant while breastfeeding. That's only true if baby receives 100% breast milk, if the baby's less than 6 months postpartum, and if baby is not sleeping overnight. So if baby's sleeping through the night, your chance of having the ability to ovulate is higher. Pumping and milk storage. There's a lot of details here about different pumps that can be used. That could be a whole nother talk. But pumping is, I do mention here, shorter durations, better than longer. So that's back to the question about power pumping. And really being cautious when you're pumping that if you are pumping, you're doing it for the right reasons, that you're separated from baby, or there's a problem with milk production, or a really severe problem with latching. But that when pumping happens, it can interfere with baby's ability to continue breastfeeding. There is a real problem with flow preference, meaning not nipple confusion, but a preference for a bottle happens when a baby is given bottles that allow for faster flow than what the breast can do. And so making sure that a baby is always given a preemie nipple with a bottle and is always pace fed, meaning the bottle's horizontal and the flow is slower, so that they don't develop a preference for the bottle. Here's a bit on milk storage guidelines. I'll just leave this here, not go too much into it. But one thing to note is this idea of high lipase in the milk. Most milk will have some odor that smells soapy after thawing it. Every woman has some amount of lipase. And it has been shown that this true high lipase in women isn't any scientific evidence. It's actually that we see that this is a breakdown of fatty acids happening in all milk, and every woman to some degree more than others. Starting solids. The World Health Organization recommends exclusive breastfeeding if possible until 6 months of age, meaning not starting solids before that. There's the reason for that is really having the immunologic benefits of the gut being truly coated with breast milk exclusively for 6 months, and how that helps with the development of the gut, if that's possible. Perinatal mood and anxiety disorders are really so troublesome and so challenging. If you are experiencing anything, here are some great resources here. Perinatal and postpartum anxiety is something we don't talk enough about. We talk a lot about postpartum depression. Postpartum anxiety, I think occurs to some degree in almost all of us, like a heightened sense of anxiety, a heightened sense of vigilance towards our baby, and that's an evolutionary benefit to protect our children. But there's a point where it becomes too much, where you are so anxious you don't want to leave the house, or so anxious that you're cleaning the bottles many times a day, and having intrusive thoughts. Intrusive thoughts, as this next slide goes into, this is a list of my colleague writing down lots and lots of intrusive thoughts that her breastfeeding moms and postpartum moms have shared with her that can be really troublesome. And just to know that most postpartum moms experience some amount of intrusive thoughts around the health of their baby, the health of themselves, the overwhelming experience of motherhood, and that's very much normal. And when to seek help is when these intrusive thoughts are actually inhibiting your daily function and affecting your ability to care for your baby, or making the experience feel entirely overwhelming. And certainly to be more vigilant about reaching out for help if you have a history of any mental health problems. I really like this slide here about a phone holiday. You know, the babies grow up so quickly, and most of us look back on this time and wish we had been more focused and less distracted by our phones. So try and put your phone away for periods of time as much as possible and really enjoy this time together. Almost to the end here, but Trash the Pump and Dump is a poster that is available on the website that I'll share. And it just talks about how this idea that moms should pump and dump their milk is so outdated. It's often shared by physicians who don't, the updated advice, but most medications are totally safe in breastfeeding. Here's some resources on where to check. There are very few that are not okay in breastfeeding. I can count them on a few hands. If you're having any sort of radiology study, a CT scan, an MRI, an X-ray, those are all entirely safe with breastfeeding. There's a few that aren't, but these are very uncommon types of radiology studies. And lastly, if you're having any sort of anesthesia, if you're getting a surgery or a tooth extraction, any local anesthesia is fine, meaning lidocaine, numbing medicine. If you're having full general anesthesia, it's actually still fine to give the breast milk once you wake up from anesthesia and are safe enough to hold your baby. So hold the baby or hold a pump. So once you're awake, the anesthesia has left your bloodstream enough to not be in your breast milk. And the indications for pumping and dumping are just so rare. And the same goes for alcohol. The ability for alcohol to make it into the breast milk in any meaningful quantity that would affect the baby is exceedingly difficult to achieve. So pumping and dumping for drinking is also something I do not recommend. Yeah, good question is what's the maximum? You will reach a point where you're not safe to be holding your baby before you'll reach a point where you have drank too much. And you actually, the data is that the percentage of milk of alcohol in the breast milk is going to be around 60% of your blood alcohol level. So if you've had 2 drinks and your blood alcohol level is 0.08, the baby's only going to be seeing 0.05% alcohol, which is like nothing compared to, which is actually less than a lot of apple juices. So a few drinks, should I say even more, is fine with breastfeeding, but what's more important is making sure that you're sober enough to care for your baby. Here in this booklet you all get is just some exercises on thinking about your needs in the postpartum period, thinking about how family members can support you, your relationships, how and when to seek professional help. And yeah, that's it. See if I have any more questions.
Discuss a little bit of breastfeeding later on. I mean, 11 months, and I was like, I feel like it's like so unfamiliar. So I fun back.
Yeah.
A whole different type of breastfeeding.
Yeah, the question is about
It feels. 10 months, you know, so like,
and the question is about breastfeeding older children. Is the question more, and I can address all of it. Is it
it's like one here a little bit now.
yeah. So breastfeeding older children is a totally different experience and one that can be equally or even more rewarding. But it's something we don't talk about as much in our culture. So I'll talk first about them.
And by the way, you know, I saw like,
Yeah.
like I don't have
Yeah, so the first thing to talk about is what it's like for the mom, and then we'll talk about what it's like for the baby. So for mom, you won't experience any engorgement to the same degree, or really none at all. Letdowns also, you don't feel as much. The milk production really goes way down around 12 months. And we talk about, babies consuming around 12 to 16 ounces, so maybe half the milk volume that they consume earlier on. So it feels different in your breast. It doesn't mean there's something wrong there. That's just what the baby needs. They don't need as much because they're getting tolerance from food. And then as far as what's happening for baby, it, from the age of 9 months till 4 years or however long you choose to go, the behavior around breastfeeding is really based on the developmental leaps that are happening. And you see that a lot of times 1.5-year-olds are wanting to nurse like a newborn again, because now they've learned how to walk and they're playing with a baby and their baby friend, and then they're having a lot of new emotions and they're wanting the comfort of their mom, and they run back to mom, and then they want to nurse, and they run back to their friend, and they come back to mom. So there's a lot of behavior around that that's pretty interesting and neat, and really supports the bond between mother and baby. And also is different than what it looks like for a newborn to be nursing, because they talk to you about it maybe when they're a year and a half or 2, or they choose to come breastfeed when they want. And so it has a lot to do with what's happening for them emotionally, and less about caloric needs. It's certainly not about caloric needs. It is very much still about immunologic and health benefits, but for the most part, it's psychologically driven and motivated by their needs for bonding. And that can look really different for every baby, and also from month to month, it can look really different.
And I'm sorry that you asked about the nipple one, they don't call that.
And
So
the
I guess that's 5 stitches, but I have like a cotton pad.
yeah, so I would say if you haven't tried try this product, I swear they don't give me any kickback, but and if you haven't tried, have using a ton of nipple butter and a gel pad to just keep a lot of moisture all the time. They're not, no, they're Polymen. They're sort of a branded, yeah, but hydrogel is what the kind of soothing gel pads are, and hydrogel over nipple butter works great as the first line. They're more expensive than hydrogel. Yeah. I think for more severe wounds, they work better, but hydrogel pads, I will say that it's totally fine to wash them and reuse them. They, I think, brand them that you have to buy more so that they make money, but you can definitely wash them. And I didn't say this earlier, but a lot of the ideas around sterilizing pump parts, that's really only for premature babies. So pump parts and bottles don't need that to ever be sterilized for a full-term baby.
Oh, how did you get my sometimes? Yeah, and when is the right time to cut it?
Yeah, we have all the good questions
I
about
have a very.
yeah. Tongue ties are another like a big controversial topic that everyone has an opinion about. And I would say, you know, it's like the two camps, either for it or against it. I'm probably somewhere in the middle, but you know, there's certainly they're a real entity. There are babies that have real tongue ties, but they're also definitely overdiagnosed. There's no question about that. Like, you know, 20 years ago, we diagnosed, I don't know what the percentage, but a tiny fraction of how many we diagnose today. And it's just no way that our whole, you know, system changed that much as a species. And it is and it's an industry, it's a big industry that people benefit from these procedures. So I am somewhat skeptical of it, but also have seen times where it's really been beneficial. So for me, a tongue tie that needs to be released is one that is causing a baby not to be able to transfer milk. So when we have a mom who has adequate milk production and a baby cannot get milk, and we really think that's because the tongue tie is limiting the ability for the tongue to move, or causing severe nipple wounds. And then you really have to eliminate other causes for nipple wounds and other causes for poor milk transfer before you come to the conclusion that it's the tongue tie, unless it's really, really obvious. But I say that, you know, having an ENT take a look is always something I find pretty beneficial, and or a breastfeeding medicine doc.
Nobody expects your baby to come back, right? And then you arrive in the tongue tie, one latch, patient is one, and then they ask you to have the baby come, and then you cut, and then they give the good bottle, and then they come breastfeed. So what do? You wait till later and until that 6 week period, and then you do the tongue tie.
So if it's a true tongue tie, the question is about when to do the tongue tie release. If it's a true tongue tie, you can definitely do it right away as early as first few days of life. I don't think there's a benefit to waiting. The comment was also about once the tongue tie has been released, now the baby's getting bottled, and that's really the problem that happens. Is a baby who's had a tongue tie release should be able to get immediately back to breastfeeding right after, like, you know, within the hour. So, and a lot of that's just miseducation around providers not knowing that how much bottle feeding can make a baby unable to get back to the breast, and just how challenging that can be. As much as bottles are necessary, there's a lot of alternatives when a baby needs supplementation, such as syringe feeding or cup feeding and finger feeding in the first few days. That's exhausting later on, but when a bottle is used, you know, very strict preemie nipple and flow, and making sure baby's getting opportunity to latch multiple times a day. That's not taken away from them, so they become unfamiliar with breastfeeding. Looks like I have a few more questions. What's the best way to determine flange size for the pump? I think a lot of it is just trial and error. Most women are really within the 24 to 27 millimeter range. And if your entire areola is getting pulled in and there's a lot of space, then go down. And if your nipple's rubbing, then go up. There's a lot of tools measuring, and I think they have mixed results. Does the quality of breast milk change after it's frozen as far as antibodies? Yes, the antibody benefits aren't there as much as it's after it's been frozen. And that's another reason that developing these freezer stashes is really of minimal benefit, not minimal benefit, less benefit than feeding directly at the breast or feeding the milk that's been pumped the day before. That's the best thing to do. And having a huge oversupply in frozen milk, although it has, some benefits and some ease of use, it's not the same as feeding directly from the breast or giving milk from the day before. Something also that a lot of people aren't aware of is that baby saliva refluxes into the ducts and stimulates different milk to be produced. So when a baby has a virus, some of those viral particles go up into the mom's breast, and the mom's breast makes antibodies in response to that. So there's a really unique interplay here that's happening directly between mom and baby that gets lost when we pump and freeze milk. Thoughts on pacifier and breastfeeding? I try not to introduce pacifier in the first few days until breastfeeding's been well established. Once you've got a baby and a mom who are breastfeeding well, it's totally fine at that point. But until baby figures it out, I think it's best to try and avoid it if you can. What do you advise about breastfeeding while pregnant? Definitely is something that for many years people have just been discouraging without data to support that. Breastfeeding during pregnancy is fine for most women. The biggest challenge is that it can be painful. A lot of women will just breastfeed less, and then when the new baby comes, they have a really enjoyable experience doing something called tandem feeding, which is feeding both babies either simultaneously or one after another. And the toddler's often really happy with all the new milk, of course, that's come in. The only caveat to that is in some moms who have risk of early rupture of membranes or preterm labor, that can be a concern about triggering some contractions. So definitely ask your obstetrician, but most cases it's totally fine. The question also comes up about, can you get pregnant while you're breastfeeding? If you're having infertility issues, should you stop the breastfeeding while trying to get pregnant? Pregnancy can absolutely happen while breastfeeding. If you're really struggling with infertility, that's something to talk to your doctor about. But most people don't feel that breastfeeding after 1 year has much impact on fertility. And that's because the milk production is so low at that time. I will send some references and things that I mentioned, and then hopefully everyone can get a copy of this booklet. I think it's a really nice resource. So thank you everyone who tuned in tonight.